is talk briefly about the brain. I'm sure that many of you work with dementia folk regularly, but I'm not sure, there might be some new folk here. So just to give a bit of a summary of how we spend many years being taught how to use our brains, how to develop good reasoning, artistic and social skills. And for us to learn and use our brains effectively, all the lobes need to communicate in an instant and in harmony, like an expertly conducted orchestra and trained. So we're able to judge situations with good impulse control generally, and with the help of these complex neural communication pathways. If we take the analogy of the brain and an orchestra and relate it to a dementia and the illnesses that cause them, they, in one way or another, gradually deplete the orchestra, player by player, indiscriminate of the role they play in the orchestra, until we're left with a very depleted and fragmented orchestra with less than half of its members in each section. Also, and it's not clear when, the conductor also collapses and leaves the stage. The depleted individual parts of the orchestra are left to make the best of their particular instrument in relative isolation to the rest of the other members. And the result is, as you can imagine, disharmony, and very regularly with our patients as we see them, those living with dementia, cognitive chaos or relative cognitive chaos. And so this, I guess, key point that I wanted to make was that it renders the person less able to respond. They are just left in a mode of reacting. They can't pull the pieces together, and so their responses to situations are more of a reaction than a response. And that leads to the very clearly defined and very real problem of what has been called behaviour and psychological symptoms of dementia. So these behavioural changes or inability to respond but simply just react, and often inappropriately to given situations, occurs in about 90% of people with dementia at some point of their illness, and quite understandably, I guess, at 80% of individuals in residential care homes where they didn't plan to end up, they also exhibit these symptoms, with their lives being a little bit more out of control than they were when they were well. It's interesting, Bradati sort of talks about non-cognitive behaviours and these symptoms of BPSD as constituting a greater problem than the cognitive decline itself, although I sort of find it a little difficult in my world to differentiate the two. So the symptoms, I mean, apathy is probably one of the greatest symptoms, but the ones that worry us as carers and health professionals, and also the family carers, are these troubling ones of aggression and wandering, depression, hallucinations, delusions, anxiety, verbal abusiveness, physical aggression, sexual disinhibition, sundowning and persistent yelling. And it just makes, consequently, our world's quite challenging, and leads to carer burden, and very often as carers we find ourselves in situations where we're tending to react rather than respond, which isn't helpful to the situation. Regardless of that though, because we are all human, these behaviours tend to cause for residents and people to be admitted to nursing homes much sooner than if they had perhaps a better responsiveness and environmental changes around them. The need, or because of the pressure of these symptoms and the effect that they have on the carers and on the health system itself, there's a tendency culturally in our society historically to want a quick fix for these problems, and that very often has been the use of the antipsychotic medications and the mood-altering ones. I think, you know, historically we've kind of, the person with dementia has the behaviour, let's fix that behaviour if we can, but I believe there's a big swing, and I hope I'm part of it, more toward that, looking at, well, how can we better respond? So we are part of the problem. We're in a way asking a person with limited cognition to function in an environment that's just overwhelming for them. And I'm sure you're all quite aware, there's a lot of research out there since 1990 about BPSDs and the overuse of antipsychotics. However, on that note, I also believe there's a real, true, and I'm sure Samantha and Patrick will talk more on that. Judicious use of these medications can make such a difference, but they're part of a bigger puzzle that we're working towards to help these people with dementia live in their world a bit more comfortably. So back to the cause, back to why these behaviours happen, and I'm sure we're all familiar with this slide, the picture of a brain quite affected by Alzheimer's disease and a normal, healthy, robust brain there. That these behaviours are signs and symptoms of disturbed perception or disturbed cognition, disturbed thought content, mood, and therefore behaviour. And it's interesting, you know, to say that BPSDs are not a normal part of dementia can take many people by surprise. But, you know, although 90% is a large number, 10% of people don't actually exhibit these behaviours changes over the course of their illness. And it's a bit like saying, you know, dementia is not a normal part of ageing. I mean, there's huge numbers, and we know that there's 50% chance of developing a dementia in your 90s, but there's a 50% chance of not developing it. So I'm really hopeful that we can feel a bit more empowered in these situations to help people with exhibiting these behaviours. And because our brains are relatively normal, it's up to us, I believe, to respond rather than react and try and understand why these behaviours are happening. I'd like to read you one carer story. I do some marking for the dementia Bachelor of Dementia Care for Wicking and UTAS here in Hobart, and this is a beautiful story. I'll just read it to you. A new male resident in the first few weeks of his admission was exhibiting agitated behaviour. The context. He was constantly walking and then running along the corridor and back again. He commanded any equipment he found and would push it up and down the corridor, and that included wheelchairs, hoists and walking frames. He got verbally aggressive if anyone stood in his way or attempted to physically stop him. This occurred throughout the day and night. Many staff were afraid to approach him due to his aggression. So the background information that was learnt was that his family reported he'd moved from a facility where he'd had very limited space to walk and had no outside access, and his family rarely visited due to distance in that facility. He was admitted to the facility for emergency respite when his wife became ill, so all of a sudden he found himself in this new environment. And interestingly, he previously had been a long-distance runner. So the response by this young carer was, or experienced carer, that I would walk and talk with him, but at a slowing pace. We would talk about his previous work, family and travels. He willingly relinquished the equipment whenever actually politely asked. Among other strategies, staff were asked to have him push the linen trolley for them, delivering towels to rooms, and engage in conversation as they went. It took about 4 weeks until his agitation eased. He still helps with the linen. So I'd now like to introduce Dr. Sam Loy and Dr. Patrick O'Brien. Dr. Samantha is an old age psychiatrist and a neuropsychiatrist who works in both the public and private sectors. She also travels to Mildura to see other patients. As well as clinical work, she's pursuing her PhD in the topic of depression in older carers, as well as researching how technology can improve the quality of life in older adults. And Dr. Patrick O'Brien is also a neuropsychiatrist at St Vincent's Hospital. He works with the Cognitive Dementia and Memory Service at St Vincent and as an old age psychiatrist for DBMAS. He has been completing a PhD in absence epilepsy now for a very long time. Thank you. I'll hand over to Samantha and Patrick.
Great, thank you. Today we'll be presenting a case on some complex case which Patrick himself has seen in his clinic, and I'll be presenting the case, and then Patrick will do a bit of a discussion, and hopefully this will illustrate some of the symptoms of BPSD which Hazel has described, and also how the combination of pharmacological and non-pharmacological management strategies are paramount. So I'll talk about the case. So this is a man called Charles, who is a 57-year-old man, not working, on a pension, currently living with his wife at home. And he presented for an assessment for his difficult behaviours. And from the notes from the GP, for the last 5 to 6 years, he's become more argumentative and jumping to conclusions. He's becoming quite temperamental, low frustration tolerance, and his wife can no longer negotiate with him. They both, however, recognise different triggers, but see things quite differently. The wife feels that she's not being listened to, the patient feels like he's not being listened to, and she feels like she needs to give him reminders and he dislikes being nagged. He does have some insight though. He can identify the triggers to when he's becoming irritable, but he can't really stop this. He can't stop losing his temper. And it's come to a point where there has been some forensic involvement. He hasn't had any charges, however, but has been quite violent, including threats of an axe, and they live out in the country on a farm. And as you can imagine, these difficult behaviours have caused significant marriage strain and carer stress on behalf of the wife. He's got an interesting past history, but not unusual. He's got a history of type 2 diabetes, but needing insulin. But he does have some poor glycemic control and has some hypos. He has had a head injury quite some time ago and has been unable to work after this time. And prior to this time, he's also had a significant history of heavy alcohol use, so approximately 10 standard drinks a day. He's on a number of medications of which we are unclear about his compliance with, and also because his wife has to administer them for him. So he's on some insulin for his diabetes, he's on some Coversil, which is an antihypertensive, he's on some Panadol Osteo for pain, he's on simvastatin for his cholesterol tablets, and that's really about it for his medications. Upon talking to him, there is some decreased raw functioning. Obviously, isn't able to do the things he used to be able to do from about 5 to 6 years ago. And he has got some cognitive symptoms, and they are more memory problems in the last 2 years, improved queuing, and it sounds like it's become a bit more concrete and difficulty with mental flexibility and sustaining attention. In terms of his anger management and his problems with tolerance and frustration, his wife says that if he is distracted and you can talk about something else, it's a bit better. At this point, he hasn't had any anger management involvement or any psychological input into this problem. In terms of his mood, it does not appear that he's depressed nor anxious. And I guess compounding the situation and what's happening now, there has been some long-term jealousy within their relationship, not delusional in nature, but there is a trait where they're a bit possessive and he's a bit suspicious of his wife and what she's been up to. However, there is no other previous psychiatric history, no psychosis, no obsessional compulsive disorder symptoms. He's not had any history of bipolar disorder either. Interestingly enough, there is a family history. His uncle and older brother also have very similar presentations. When we reviewed him, it was quite clear that there was a lot of conflict between Charles and Anne, and Patrick will go into this in more detail, but they were argumenting a lot. It was very hard to get any proper history from the both of them together. However, when seen separately, you were able to get more history from both Charles and Anne. And from Charles' perspective, he does feel like he's been victimised and been a target, like a scapegoat in his family. With regards to his most recent MRI, upon looking at it, there is some white matter hyperintensities, perhaps suggestive of some vascular disease, and there is some just some slight atrophy. And you do have access to some of his previous neuropsychological testing, and this was from when he had the head injury. That was in 1991. Oh, sorry, in 2008, so only a few years ago. And the deficit at that point was that he had difficulties with verbal reasoning and recall, but as we mentioned before, improved with structure and cueing, and this frontal executive problems where he has some poor organisation skills, poor planning, and a bit rigid and not very flexible with his thinking. But this apparently has been long-term since the motor vehicle accident and the head injury in 1991. But his strengths are that he does have good visuospatial function, and that's okay. So, the current issues as we saw them was obviously the anger and irritability, which is causing quite a lot of conflict between him and his wife and his function. There is some cognitive impairment, which has been seen in the past, and there are significant risk factors, which Patrick will talk about soon. And we do have some imaging which shows there are some abnormalities potentially, and these obviously mean that further assessment is required. The other thing is that there is some conflict within their relationship, and that's probably exacerbating his cognitive and anger difficulties, and there's some stresses which we obviously need to find out about. So these include obviously the relationship between the two of them and their past history of perhaps a more possessive, jealous relationship from his perspective. There's difficulties in communication style where he feels like he's being nagged and she's feeling that she's not being listened to. And this ongoing conflict within the family where he feels that he's being scapegoated. So what I'd like to do now is perhaps pass on to Patrick to talk a little bit about an assessment and management, what we would do for someone like this man if you're given this case, and also talk about what our next steps would be. So I'll pass over to Patrick.
Thank you very much. I remember this patient very well. I'm sure all of the doctors in the audience will have had a similar situation where, firstly, you're quite struck by a family, not just the patient who has the problem, but a family who really are in crisis. You're given as much information as they can provide at the time, and it's quite difficult to know where to start sometimes, especially where there are a number of different agendas that need to be addressed. So my job, really, when I saw this patient, I saw him twice 6 years ago over the space of 3 months. My job to start with was to make a presumptive diagnosis as to what the problem was and to give them an effective management plan. The first thing that I had to do is I had to control the interview to take a history, and there was a significant amount of stress from both Charles and Anne when they first entered the room. I ended up separating the two of them and taking the history together separately, and when that happened, I could get both Charles and Anne to identify with the priorities that we had to address, and we had quite a productive interview over the course of 2 hours that it took. What I had to be clear of to start with was that in his presenting complaint, firstly, there was a change in his behaviour, even though his head injury was 20 years previously. What was it? 15 years previously, excuse me. And what was an organic problem from a neurological sense, and what was a psychiatric problem. It was quite clear over the way they described his difficulties with anger management that it was an organic anger management syndrome. And the reasons for this is that he was really very reactive, disproportionately reactive to quite small triggers. He had very little time to process these cognitively before he would react. He was quite non-reflective. There wasn't much planning as to how he dealt with these stressors, and he was quite impulsive. And all of those really are indicative of an organic frontal organic anger management syndrome. It was quite stereotyped, and there were identifiable triggers that he had some insight into, and his wife also had into as well, and that's important. We'll talk about the reasons why in a second. The most important thing that came out of the discussion was that he had a really deep sense of remorse. He wanted to keep the family together, and both he and his wife felt that this was really a crisis for the two of them. His wife showed me a carotid endarterectomy scar that she'd had a number of TIAs in the past, and stress was a big problem for her. On his mental state examination, he had other indicators of frontal lobe impairment. He was quite jocular and a bit disinhibited, but he settled to containment with me, and I could chat to him for an hour without any problems. I went through the history around his aggression in the past, and without and both of them agreed that all of the cases of aggression that they could identify, there seemed to be the same pattern of triggers that we've already discussed. There wasn't a psychiatric component in the sense that he wasn't depressed. In terms of the jealousy, there wasn't any psychotic phenomenology behind any of that. And so what we had to do was we had to move on to how were we going to assess what was the basis of the deterioration in his behaviour. And from a cognitive standpoint, this is a seminar on dementia. So the real question is, does he have a neurodegenerative illness or not? In the history, it wasn't clear at all whether he had an amnestic component to his presentation. So if ever you get time, Google the frontal behaviour inventory, it's called. It's actually a very good carer informant questionnaire and also patient rated response questionnaire for frontal type behavioural change. And if you ever have patients with whom you might suspect have a FTD or have any type of frontal impairment, for example after head injury, it's actually a very good instrument for getting a sense of what is the syndromal nature of problems. So if you think about frontal lobe functioning in terms of anatomical regions, you want to look for example, motivation, mood, incentive, related changes, how people respond to routine, insight, judgment, impulsivity, gambling, what else? Executive function and planning, all those other sorts of things. There are about 26 items on this scale that I don't have in front of me. But if you Google it through, I think it's through the Canadian Journal of Neuropsychology, you'll find it very useful, and it's a PDF document you can download for free on the internet. So we went through that. What we should probably do then is look at what in the environment are contributing to his behaviours. At this point, what I often do in my clinic with patients who have these types of symptoms is I try and elicit both from the patient and also the carer what do they think is relevant to the triggers they can identify with the deterioration in the behaviour in the environment. One of the biggest problems that this patient had was that he had no real role functioning. So over the last, I think around 5-10 years, he hadn't been working since his head injury. There was not a lot for him to do during the day. He didn't really have a set structure and routine, and there are complicating factors in terms of his family, in his son and daughter, in terms of psychiatric problems and behaviour, which I actually haven't got into because I wanted to keep this much more relevant to the patient. But all of those were contributing to the sense of stress in the environment. The second problem was what was a communication style between the patient and his wife. And let's come back to the neuropsychology testing results that you have. So here you have a patient who has quite limited verbal memory and verbal reasoning. He has limited planning and ability to organise information that is given to him verbally. And one of the things that I was told when I first met Charles was that he doesn't listen. The other thing that I was told when I interviewed Charles separately was that he feels quite victimised within the family environment, and that there seemed to be this pattern of, for want of a better word, blame. Let me digress for 1 minute at this point. I have been a carer for both of my parents, and one of the things I can tell you, stepping outside of my doctor's role for a second, is that cognitive impairment tends to creep up on carers in the family. And it's, even if you have the sort of training that Sam and I have, it's quite difficult sometimes to be objective about what you see. One of the things that I had to do when I met this patient was I had to elicit from them a pattern without in any way being seen to judge or blame or point finger at what was going on. The next thing that I had to do was I had to organise an immediate management plan and a further assessment for getting down to that key question as to what was the diagnosis for this particular problem. If I was to take an informal poll amongst the people listening, I wonder what percentage of you would think that this man actually has a neurodegenerative illness. The answer at that stage when I first saw the patient was I really was not sure. There were a lot of the features in the history that were long-standing and that seemed to be slowly progressive. When he had his neuropsychology testing in 2008, he had quite an uneven cognitive profile in the domains that I've already mentioned, but that none was suggestive of a neurodegenerative illness at that time. Similarly, he didn't have, on imaging, he had a little bit of ischemic, subcortical ischemic change. He had a little bit of atrophy, but there wasn't that was clearly suggestive of a neurodegenerative process. So the first thing that we had to do was we had to organise further imaging, and he went on to have a SPECT and a PET scan, and he also had a repeat MRI scan 2 years later, and he also had repeat neuropsychology testing as well. Let's leave all of that aside because I'll come back to immediate pharmacological management as well. So to do the pharmacological approach first, and then I'll come back to non-pharmacological approaches. We heard Hazel mention the over-prescription of medications, but we also heard Hazel mention that when used judiciously, they can work extremely well. And I'm actually very glad to say that in this case, that's what happened to Charles. He had a very good response to a low dose of risperidone, which he tolerated quite well. When we increased the dose up to, I think it was 1 milligram twice daily, and we also tried a 3 times daily regime, but he just got increased side effects of tiredness during the day. It didn't clearly benefit, so we left it down at that low dose of 0.5 milligrams twice daily.
Can I ask, why did you pick risperidone rather than any of the other antipsychotics?
I picked it firstly because rather than olanzapine, which is more anticholinergic, and given that he has insulin requiring non-insulin dependent diabetes, I thought risperidone would be reasonably better tolerated. I knew that with any antipsychotic, like for example, ziprasidone has a more sort of what's the word I'm looking for? A more even metabolic risk profile, perhaps people might argue. But the thing is, this man needed much tighter diabetes management anyway, and he had an excellent GP, and I thought all of that could be managed. The second thing is that it's available on PBS, and he actually responded very well.
Great, thank you.
That's right. So in judicious use, this medication can be very helpful, and especially if you have patients who have insight into their organic anger management that they really, you've got them on side and they really want some assistance in managing it, this can be a situation where these medications as a class can actually be quite helpful. So let's come back to non-pharmacological strategies. This is probably the significant most important aspect of the case. So before the patient left my room the first time, I got an agreement from both of them that firstly it was a problem that it required specific management. He'd never accepted referral to a psychologist previously, but he did at this particular occasion. And when I saw them both in 3 months later, I was very pleased to hear that both he and his wife could see an improvement. One of the things that probably helped them the most was both myself and then the psychologist later took them through aspects of the communication given his cognitive profile, some of which could be productive and some of which could be counterproductive, and being overloaded with verbal information and managing stress within the family were the ones that they managed to work on most significantly. Secondly, they managed to develop a routine with activities that he enjoyed. There were many more long-standing issues between their relationship, which I won't go into, which I never really found out whether they had successfully managed over time, but which they certainly had embarked on when I last saw them 5 years ago. So let's go back to imaging and the question of what this patient's diagnosis really is. It's reassuring to hear that he did better with support, with routine, with structure, with targeted communication strategies, and with the risperidone. And in a sense, in the way that I've painted this patient's cognitive impairment, you would expect that he would do well with a management plan like that. The SPECT scan showed that he had some bilateral temporal and parietal hypoperfusion, but when repeated, that plus the MRI scan didn't show any progression after 3 or 4 years. So the answer to the question is that this man does not seem to have a neurodegenerative illness. He doesn't actually have a dementia. However, he certainly is at risk, especially with regards to vascular disease, of developing increasing cognitive impairment over the past. The second thing to say is that probably the reason why his behaviour had deteriorated over the last 5 years was also probably because of those risk factors mentioned above. So he certainly is a patient that needs to be watched carefully over time. He doesn't have frontotemporal dementia on the basis of the investigations that we did. And interestingly, his family history is a concern, but having said all of that, his neuropsychology deficits actually haven't progressed over, I think, 5 years of interval testing. That, for most patients, but not all, would tend to rule that diagnosis out.
At this point.
At this point.
Yeah. There's a good news, there's a little good happy ending to this story, as Patrick mentioned before, that 3 months later when he saw them again, there was actually improvement in terms of his behaviour, the conflict within the family and the communication. So it shows that even though we don't like to give medications unnecessarily, sometimes you need to give a little touch of it just to take the edge off, and perhaps then things are a little bit easier to manage. And this case illustrates that with this medication, with both Anne and Charles both agreeing to it, that actually helped the case. And the counselling and the strategies of communication and giving him a role to play was actually very important. There is a question here saying, why not use SSRIs or SNRIs? And I guess it's about, whether there's a factor of anxiety or depression there in this case. And I suppose when Patrick did review this man, he did not think that at this point his mood was significantly depressed or anxious to require and justify an SSRI or SNRI at this point.
The other thing to say is that, I can't read the comment, but the other thing to say is that SSRIs do have an evidence base for reducing impulsivity, and if anxiety was significant in the presentation, then that would have been the first thing to do. You're right. The second thing to say is that compared with antipsychotic medication, it does have a more beneficial side effect profile given vascular risk factors. But I went for risperidone because of the severity of his anger management problem. That's really my reason for it anyway.
Yep. So the other question was the communication and behaviour problems which this man presented is totally attributed to his previous problems and his perhaps brain injury?
It's a combination of all of the above, but also the combination of all of those things and the long-term problems within the family and in the relationship.
Loss of role.
And the loss of role and the loss of structure and routine. And, that old saying in medicine where you have to replace the patient's symptoms with something. And what really got this patient better, I think, was structure and routine and support over the longer term.
Yeah. And there's no reason to say, look, he's got risk factors and he may develop symptoms of an FTD in the future with his risk factors of the vascular changes, the alcohol, and maybe even the family history. However, time will tell, and he may have ongoing review from his GP with his symptoms. And of course, if there's a deterioration in his symptoms, then of course it's worth repeating an assessment, having more imaging, and having more neuropsychological testing. However, we wouldn't do this within 1 year. You'd have to wait at least 18 months' time, 18 months, 24 months' time to see whether you can capture such a deterioration in his cognition and his imaging.
In the memory clinic, what I often say to the patients when we feedback diagnosis of dementia, I say to them that the national average of diagnosis is about 90% for Alzheimer's disease, let's pick. So what that means is that there's a 10% chance I could be wrong, and so that it's always important to review, firstly, whether or not the diagnosis makes sense with the patient presenting symptoms and with the objective evidence on examination and investigation results. But secondly, that it should be reviewed by a specialist every 6 months or so, and I usually send the patients to a private geriatrician or neurologist after they've been diagnosed and started on a cholinesterase inhibitor. But the most important thing is review, because the other thing with all of these, with dementia and also with this patient, is that the behaviour and psychological symptoms of dementia are phasic. They come and go. They also there are changing challenges with the stage of the patient's illness and also with the environment and their needs.
Yeah. So I think the take-home message is that regardless of what you're doing, you probably need to be reviewed anyway, whether it's by a GP or another specialist, to see, look, does he need to continue the risperidone and what's happening with the wife and the strategies, and these things may continue to change, you know, regardless of whether, for example, this man has an FTD or not, but also if anyone with behavioural and psychological symptoms of dementia. And again, someone also mentioned, was his glycemic control improved? Well, that would also be very important, and we probably should have mentioned that, knowing that he does have poorly controlled diabetes, making sure that his insulin regime and that his blood sugars are stable is also going to certainly help with his behaviours and also how he's feeling and his frustration tolerance. That's definitely something important.
That was addressed,
and
actually.
That was addressed?
That was addressed, yeah. Thanks for reminding me.
Thanks for reminding us. I think that's all we've got to say about the case, Hazel.
Unmuted. Okay, thank you, Sam and Patrick. That was really interesting, and thank you for watching the questions as they've come up and answering them. Hopefully we might get a few more. I had a question about productivity in the role, because like a lot of my work is in nursing homes, and how important do you see that loss of productivity in the elderly folk in residential care homes as well?
Oh, we would see it a lot.
Yeah.
I think it's a huge thing. It's a massive transition to move from independent living to residential care. Sometimes the person themselves agrees or doesn't agree they need to go, and at least at home they were able to do something, whether it's a bit of cleaning, a bit of, you know, preparing meals. In residential care, often that can be taken away. So taking consideration of the person's story and their previous job and what they used to do at home, and providing some kind of role or substitution, or at least having to understand that they say used to be a runner or used to be this particular person, and that might help them think creatively of what they could do, whether it's help around in the garden or, you know, move the trolleys. And it's hard because I know there's lots of health and safety issues, and I know a lot of facilities do worry about, you know, they want to make this person a slave, for example. So it is definitely a tricky thing, but talking to the family can also help create some ideas and perhaps come up with a plan of how this person can be given a role.
Yeah. I think it's because everything else in management, such as medication or, for example, stabilising the patient's sleep-wake cycle, or you know, giving the medications chance to work, is about having a structure and a routine that they enjoy. So if you think about any neuropsychiatric symptom of dementia, incentives to engage the patient is the most important thing, because otherwise your management's not likely to be successful.
Yeah, it's interesting, isn't it, how they have to, as you say, just really work in harmony together. There's a question here about occupational therapists in nursing homes. I think, in my experience, we have nursing homes can call in occupational therapists to do specific assessments. How is it in Victoria, in Mildura?
It's the same thing. Often they may be a leisure lifestyle coordinator if you're lucky, and you can get OT assessments, but sometimes you may have to pay. So I think it probably varies from facility to facility, yeah. I suspect. In metropolitan Melbourne it might be a bit different. But they can be obtained, but sometimes you do have to pay, unfortunately. But they can do often very good sensory assessments and help if the person, for example, has got hearing or visual impairment. They may be able to suggest really good ways for them to use their other senses to engage them in other activities.
Yeah.
And I think it depends on where you are. For
sure, yeah. And Montessori just falls into my mind a lot, like those Montessori activities where they're purposefully, purposeful activities. And I know that some residential care homes are actually employing those care folk who are trained in Montessori techniques. Specifically, have you noticed any facilities that employ that method that have more success, would you say, or?
I think it probably depends. Again, I'm not really clear. I think different facilities may have different expertise. I know recently in the paper there was an article on Montessori techniques and how this was really valuable engaging people. I know there's quite a lot of literature and some facilities do that. But from my experience, I haven't seen for example, in Mildura.
Right, yeah, no, thank you. It's just interesting. Yeah, any other thoughts, or there's no further questions popping up at the moment? Yes, I find it's a fascinating illness, and then we pop these folk that can't think very well in the middle of a situation they just don't want to be in, and finding the that support and feeling that feeling of support. Yeah, asking the carers, the formal carers, to put that in place is quite challenging, but so rewarding, as you say, and it can be just a simple regular word of support that can make a big difference. Okay, well, I think Sam and Patrick need to head off. They've got an appointment they need to keep, and I do understand that the slides and this presentation have been recorded and will be available later, but I might ask Seniel to confirm that when she comes back online. So thank you, Sam, and thank you, Patrick, for a most interesting presentation, and all the very best.
Thank you.
Thank you.
Take care.
Okay, bye-bye.